Vipul, Dhruvi, and the team, the Vidisha, and the whole team who is organizing this practical diabetology. So I'll just talk about BMI, why it is of no use. My talk is beyond BMI. That means we need to understand that BMI is not being giving us the proper information. Body mass index has been cornerstone till now to tracking the obesity trends since so many decades. But growing evidence suggests that it failed to tell the true story or complete story of a health and body composition. It was born in 1830, still making medical decisions today, which is really sad. The developed by Adolf Kotelett as a population statistic, not as a health measure. And it was started in 1823. So there are so many changes which happened, but WHO also used as a definition of BMI in 1991 to define obesity. BMI was never used for never meant for clinical use because there is no assessment of fat distribution or health status only by BMI. What BMI misses, not all weight is fat and not all fat is unhealthy. Like a muscular man is having more than 34 BMI with fat percentage of say 10%, that doesn't mean that he's obese. He's healthy, but still the BMI may be high. So if you look at all wrestlers and all, they have high BMI, still the fat percentage is low, so that means they are healthy. So no insight into visceral fat, sarcopenia or fat quality. So there are better measurements which are available to understand the body composition. One is waist circumference. Research shows that waist circumference is stronger predictor of health risk than BMI. For a given waist measurement, health risks are similar regardless of whether someone is classified as normal weight or obese or by BMI standard. Other indices like waist to hip ratio and waist to height ratio may offer additional insight, but simple waist circumference remain a practical clinical measure to define obesity. There are other technologies, other methods which are there, like bioelectric impedance analysis, that is BCA. We have dual X-ray absorptiometry, that is DEXA scan. We have MRI imaging. There is computer tomography, which can also assess the fat percentage of body, and 3D optical scanning, which is coming up, wherein one can scan with the 3D and they can measure the subcutaneous fat and visceral fat. So there is ethnic and genetic bias on BMI. The South Asians develop metabolic diseases like diabetes and coronary heart disease at lower BMI. The women and elderly people are misclassified because of the BMI. Sarcopenic obesity and thin fat phenotype is a problem. Normal BMI people can have metabolic risk because of the high percentage of fat. So they are metabolically sick people. Central obesity means more BMI. The waist to height ratio more than 0.5 predict cardiometabolic risk, which is better. Similarly, body composition triumphs which are beyond BMI are BIA, DEXA and MRI, which can precisely predict the adiposity of a person and the lean mass, that is a muscle mass. In real world, consumers using BMI, it delays the diagnosis of obesity and that leads to inappropriate denial of the therapy. Like somebody who was referred at say 30 BMI with metabolic disease are not offered or advised surgery just because of the BMI, even though they are unhealthy. Similarly, GLP-1 access or other issues like restricting BMI-based criteria limit access to weight loss medications. So surgery is eligibility because of the BMI cutoff. So who decide and who qualifies? Actually, the insurance companies had decided the BMI criteria to have a qualification of bariatric surgery, and traditionally BMI more than 35 is outdated. Now, new guidelines published by international federations for surgery for obesity and metabolic disorders, wherein they qualify 30 plus BMI with medical risk factors who are eligible for a bariatric or metabolic surgery. Rubino Commission, which was published in 2023, says that obesity is an adiposity-based chronic disease, and they recommend the abandoning of the BMI as a sole diagnostic tool. So it is time to diagnose obesity holistically, consider function, risk, and adiposity as a measure and not just BMI. This is a clinical scenario wherein a BMI of 29.5 having severe NFLD, PCOS, insulin resistance, and they are denied of bariatric surgery or metabolic surgery. So there is another publication or Edmonton obesity staging system from Canada, which is published and being used nowadays to assess and grade the obesity. And they never consider BMI as a diagnostic tool or criteria. So better tools are waist to hip height ratio, BIA, or metabolic clusters, and liver fat percentage if you can measure. It advocates the insurance to change the guidelines and to reform the guidelines. In bottom line, BMI is a screening tool, not a decision tool, and don't let it keep our treatment or care. This is just a practical example. I'm just sharing with you. This is Sabu Narwaria. Everybody knows both of us. So this was first week of this month. We both were traveling together. So we did an analysis of our body composition, and even though his BMI was lower than me, we have found some changes. So this is a body composition. If you look at, which one is marker here? Okay. So if you look at my weight is more than his weight, is 88.5. His 79.8. Muscle mass is 33.8. His 29.3. Fat percentage is 32.8. His fat percentage is 33.7. So look at the BMI, which is significantly lower. Weight is significantly lower than me, but still the fat percentage is more. That means he is at a more risk of developing metabolic complication. So I asked AI tool to analyze our data, and this is what we found. So if we look at the comparison of Dr. Sabu and me, almost similar height. Weight is almost 8 kg lower than me, 8-9 kg lower than me. BMI is again lower than me, but fat percentage is much higher. And if you look at another fat distribution, there is central obesity, but I have even fat at the limb. And phase angle, that means cell health is better in my case versus him. And the clinical implication of this analysis is that more visceral fat, lower muscle mass, that indicates higher metabolic risk, higher muscle mass, better cellular health, relatively preserved metabolic health. So even though there is high BMI, still I'm healthy, I don't have any medical problem so far. So BMI does not fully capture body composition. The management approaches differ for each individual, like he has to work on muscle mass gain and reducing the fat percentage, and I have to reduce fat percentage. So I have more muscle mass, Sabu has higher central obesity and higher risk. The Indian phenotype shows lower muscle mass, need body composition analysis in our clinic to analyze this kind of paradox, and higher visceral fat and insulin resistance and global BMI cutoff don't fit into Indian risk factors. So BMI alone is insufficient for Indian obesity care. Incorporate this paradox in medical teaching and workshops, personalized treatment based on body composition, and consider visceral fat, muscle, and fat pattern which has to be changed. So this is a Lancet commission which is being talked about recently, which was published in January 25, wherein they have defined preclinical obesity and clinical obesity. A clinical obesity means excess body fat associated with variable level of health risk, but no ongoing illness. That means people living with preclinical obesity have no evidence of reduced organ or tissue function due to obesity, can complete day-to-day activities without any problem, are generally at a higher risk of developing disease like central clinical obesity, which can always progress. The preclinical will progress to clinical obesity. There is a high risk of cardiovascular disease, some cancers, and type 2 diabetes. So if we can treat preclinical obesity, it is the best way to treat these patients. And the clinical obesity means a chronic disease due to obesity alone, characterized by signs and symptoms of ongoing organ dysfunction and reduced ability of a person in their routine day-to-day activities. People living with clinical obesity have reduced tissue or organ function due to obesity, such as breathlessness caused by obesity on heart and lung, knee or hip pain, joint stiffness and reduced movement. The cluster of metabolic abnormalities like IHD and hypertension and other problems, and dysfunction of other organs including kidney, upper airway, nervous system, urinary system like urinary incontinence, and reproductive system like infertility. So these are the people who are classified as clinical obesity. So this is the same. So Commission's critique for BMI is a failing matrix. That is, BMI is a failing matrix. BMI is a population level tool, not meant for individual clinical decision. It ignores the fat distribution, with whether it is visceral or subcutaneous fat, metabolic health, that includes insulin sensitivity and inflammation, body composition, the sarcopenic obesity, metabolically obese but normal weight people, metabolically healthy obese people, the ethnic variability like South Asians, East Asians, and high visceral fat at low BMI. BMI lacks diagnostic specificity, sensitivity, and relevance to health outcome in individual patients. So the clinical message is that it reframe obesity as a disease, not as a number. Diagnose based on adiposity and impairment, not by BMI. Refer for surgery or medical management, even though the BMI is lower than 35 with existing comorbidities. Advocate for access, equity, and evidence-based thresholds. So takeaway message is BMI is simple, but obesity is not. Let's give your patient a better tool and better care. With that, I complete my talk. Thank you.
Thank you so much, sir. And we'll take the questions by the end of